All right. I should probably put on my microphone. Hello, everyone. How's it going? So, everyone saw the PowerPoint to download, right? Hopefully, yes. So I was looking at the schedule and I was like, wow, that's a 2-week turnaround time for my test. I said, that's really rough. I've never had 2 weeks between tests in my class before. And so I said, that's real rough. So I'm gonna, and then it's like 5 weeks until the last one. So I said, that's less rough, but I feel bad if they have like an assignment due on Friday when their test is on Monday and they've only had 2 weeks to like really kind of help digest the material. So I said, let's push that assignment off by another week. So that one's going to be due next Friday, which I think is October 3rd or something like that, 4th, whatever day it is. Yeah, it's next Friday by midnight. So a little bit of leniency my way, but you won't think that when you actually get through all the material, because we got 3 more class sessions and then the test on Monday. So this is a lot of stuff to try to internalize. However, it's good because you covered a lot of this stuff in cardio already, so this will be kind of treading similar ground, okay? Any questions before I get started? Anything from like the last section where we're talking about hyperlipidemia and all of that? No? All right, let's continue on then. I'm using a different microphone this time, so I want to see if that helps out the audio quality at all. Yeah, my laptop one's not great, and I don't want to bring up my big giant microphone. So because of that, if I lose all the audio today, then I'm very sorry about that. We'll see how it goes. Anyway, so no questions starting out. Perfect. Let's get into diuretics. What do diuretics do? They diurese you, they make you pee, absolutely. Basically, anything that is increasing urine flow, we're going to be calling a diuretic. How do we cause diuresis to occur? Well, all has to do with where salt's going, right? When I say salt, I'm primarily talking about sodium and chloride, but also what other type of salts do we lose to the urine? Potassium, calcium, magnesium, right? That's one of the main ways we're balancing the electrolytes in our body. All these salts is basically through the kidneys here, and so you're going to find that when we look at our different classes of diuretics, they're going to have different effects on the electrolytes, and so it's really important to understand how they're all working, where they're working out within the nephron to cause these different imbalances. And so one general rule of thumb that I want you to know when we're talking about diuretics is that wherever salt goes, what likes to follow? Water follows, right? So it's a very good rule of thumb to know. That works in the body as well. So from doing something that causes increased salt reabsorption, that's going to cause reabsorption of what else? Of water. They're very good, right? So if I'm causing increased excretion of salt, water follows that as well. That's how we get that diuretic effect there, right? Based off of osmolarities and tonicity and all that kind of fun stuff. Anyway, what happens if we have too much volume on the body? It builds up, you get edema, you can have ascites, you can have, what's one place we don't want water to back up into? It could be potentially deadly. The lungs will be really bad, right? Pulmonary edema is no good if you can't oxygenate because the alveoli are all full of water. And obviously if you have too little, then you get volume depletion, you're going to have cardiovascular collapse. There's nothing in the hoses, so to speak, in terms of volume, so we got to fill that back up in some cases. Anywho, kidneys, they receive a decent amount of the cardiac output, but they end up using a ton of energy, as it turns out, because they have to run all these different pumps and everything like that in order to make sure we're balancing water and we're reabsorbing things like we're supposed to and excreting things like we're supposed to. And there's a lot of compensatory mechanisms built into the kidneys in order to maintain our blood pressure and our heart rate and all that good stuff. And so you've already covered things like the renin-angiotensin-aldosterone system, correct? Please have heard of that before, talking about things like antidiuretic hormone, atrial natriuretic peptide. All these different things here are going to be influenced by the kidneys because they're going to be the ones kind of regulating a lot of these systems here. So for instance, if the kidneys detect that they're not getting a lot of blood flow, what do they do to fix that? They increase the expression of the renin-angiotensin system, right? So renin gets upregulated, that stimulates production of what? Angiotensin 2, and it helps to stimulate aldosterone and norepinephrine release from the CNS, and it does all these things to try to get blood pressure up. By increasing blood pressure, it sends more volume to the kidneys, and guess what? Now they feel like they're being, that's what I'm thinking of, perfused enough, thank you. They're being perfused enough, and now they can then turn off that renin-angiotensin system, right? So there's a lot of balances here, and what you're going to find is that anytime we're adding on like an antihypertensive or anything that disrupts this system, you're going to find that's one of the big compensatory mechanisms. And so we have what they call diuretic braking, where you can give a diuretic all day long, but the kidneys are eventually going to try to resist that because they're going to detect, hey, we're getting rid of too much volume, there's not enough salt here, I need to do something to help fix this issue. And so you tend to find that a lot of your antihypertensives, diuretics including this, are included in that. They tend to have good utility, but only up to a certain point, because then those compensatory mechanisms will kick in to try to maintain that homeostasis. So one thing to kind of think about. So looking at the kidneys, we're going to be focusing mainly on the nephron, since this is going to be kind of our main functional site for the kidney itself. And so first off, kind of what happens, what's like the first place like blood kind of gets filtered? Basically in the glomerulus, right? That's probably a bad way to phrase it, but the glomerulus is where we're going to see most of the filtration happening initially. What gets filtered at the glomerulus?
Things go through.
A lot of small things go through. Remember those little fenestrations, right? Those little gaps, things like salt and bicarb and glucose and amino acids, all these things can go through. However, does all of that end up in the urine? No, we're going to see there's a lot of sites of reabsorption that occur here. And so this is really kind of important to understand all the different parts of the nephron, where things are being reabsorbed, and then how our diuretics are affecting that. So you've already covered all of this in your physio class, and in probably some in pathophys, and probably some in CMS with Dr. O, right? So I don't have to repeat any of this stuff. You can just I'm just kidding. I'm going to go through it, right? Anyway, so filtration is the first step that happens here at the glomerulus. A lot of different solutes are going to be going through that glomerulus, get filtered. And again, most of these do not end up in the urine because we have these reabsorption pathways. We have these pumps that are going to help to reabsorb a lot of these different products here. And again, we're getting a lot of filtration happening through the glomerulus, right? What do you call that rate of how fast things are getting filtered? GFR, it's your glomerular filtration rate. That goes down. That usually is indicative of not enough flow getting to the kidneys or something else going on there. How do we determine what a patient's GFR is normally? Yeah, we use creatinine clearance as sort of a surrogate of that, right? We measure creatinine. Anyone know why we use creatinine? It does not get secreted into the nephron. It does not get reabsorbed from the nephron for the most part. And so because whatever gets filtered gets eliminated in the urine, that gives a really good idea of, by measuring that, we can say, okay, well, we have a good idea of, and again, how would you measure, what's like the most accurate way to measure creatinine clearance? You do 24-hour urine, right? Because you can just basically collect whatever is in the urine, you figure out how much there is, and you say, well, that's how much they filtered throughout the entire day, so that must be their creatinine clearance, right? That's their GFR, essentially. However, is it convenient to do that? Carry around a big jug full of urine all day long? No, no one wants to do that, right? So it's like, let's just do a blood test, much easier. And so we came up with those equations, things like Cockcroft-Gault, that let us know, like, okay, well, if your serum creatinine is this, it should be indicative of a creatinine clearance of this, based off of age and weight and all those different things. Anywho, so that's why we end up using that as a surrogate for GFR, because it's much more difficult to get a really accurate number on that. So anyway, so we see a ton of filtration happening here. Plasma getting filtered constantly to remove a lot of waste products and help make sure we're balancing salt and water and all these different things here, right? So the first thing we're going to be hitting is going to be the proximal convoluted tubule, and this is where you see the majority of reabsorption. Almost all your glucose gets reabsorbed here, almost all of your bicarb gets reabsorbed here, a lot of different salt, sodium, potassium, things like that all get reabsorbed here. About 60 to 70% of that filtrate actually gets reabsorbed at this point, right? And again, normally when you say do like a urinalysis, do you find a lot of glucose in a healthy patient's urine? No, because the proximal convoluted tubule is doing its thing though. However, can you overwhelm that system? Absolutely. So if you have a diabetic patient who maybe is overwhelming the kidney's ability to reabsorb that, then you end up finding there's going to be a lot more glucose in the urine. There's actually a new drug, we'll talk about this in the endo section later, talking about diabetes. There's now a new class of drugs that actually block reabsorption of glucose directly and cause you all just to pee right on out. And that's how they can manage blood glucose that way. What do you think that puts you at risk for when you have a lot of glucose in the urine? UTI is actually a fungal UTI, which is really kind of interesting. So again, sometimes think about the pathophysiologic, sort of implications of some of these drugs here. Anywho, so proximal convoluted tubule, a lot of reabsorption happening here. There's probably going to see that when you have a diuretic that affects the proximal convoluted tubule, it has kind of the weakest action. So why do you think that is? So if I block reabsorption of salt here in the proximal convoluted tubule, where else does it have to go through? Loop of Henle, distal convoluted tubule, collecting duct. There's a lot more places for salt to be reabsorbed, and so because of that, because you have all these other places that can sort of pick up the slack, so to speak, the diuretics that work here really aren't that great. Right? They're going to be pretty minimal. However, they do have their places, but just know this is one site where our diuretics are going to be working. Up next, we had the loop of Henle. It's actually named after the singer for the Eagles, right? I'm just kidding. You guys actually know who the Eagles are? Wow, good taste, good taste. Anywho, so loop of Henle, what's the big thing that's happening here? Well, basically, this is a major site for concentrating the urine, right? So based off of how long this nephron is, or how long the loop of Henle is, how far it projects into the kidney itself, you're going to find that you can get a lot of concentrating effects that happen here. And the reason why that happens is because on the descending portion here, you find that this is relatively permeable to water. However, on the ascending portion, what happens? What changes? Water's going to be kind of filtering out here, but the big thing here in the ascending portion of it is you're going to find that there's a lot of reabsorption of salt, right? So sodium, chloride, potassium are going to be a big thing that helps it get reabsorbed here through the ascending loop, okay? And again, this is important because you remember, you ever talked about that counter-current multiplier, right? I'm not going to get super in depth on that, but that's how you basically cause this actual concentrating effect to happen here. So that way you reabsorb a lot of that water and you leave very concentrated urine left over, okay? Don't get too lost on that. Just know a lot of salt reabsorption happens in the ascending loop of Henle. Okay, and we block that, then you block a lot of salt from being reabsorbed, and that causes a lot more water to be excreted through the urine. So this is actually one of the most potent sites that your diuretics can work. Even though it still has to go through the distal convoluted tubule and the collecting duct, it can't really pick up as much slack because this is one of the most kind of prominent sites there where we can interact with the system. Okay, so just know whenever, and again, what type of diuretics do you think I'd be giving that would affect the loop of Henle? Loop diuretics, right? So sometimes the name expressly tells you kind of where it's working at in the kidneys, which is pretty handy for memorization purposes. So this is where our loop diuretics are going to be working. Anyway, next we get our distal convoluted tubule. You're going to find this is most of the salt that needs to be reabsorbed in the urine has already been done so by the time it hits or exits the loop of Henle. So you find this is relatively weak in terms of sodium reabsorption. However, we can find this is where aldosterone starts to play a role in the distal convoluted tubule, also in the collecting duct, but this is where our thiazide diuretics are going to work. Has anyone mentioned any thiazide diuretics before? Like what's an example one? Hydrochlorothiazide gets abbreviated as HCTZ, right? One time I had a patient who came up, I was on a community rotation, I think I was at a Publix, the guy came up and he's like, I need to get my refill of my Huctaz. And I was like, what? I said, I need my Huctaz, and I was like, write it down for me, right? HCTZ, and I said, okay. Technically you're correct, so okay, here you go. Anyway, finally then we have our collecting duct, and here you're going to see this is where aldosterone is kind of being a little bit more prominent in terms of it affecting both sodium and potassium reabsorption, and then also this is where antidiuretic hormone comes into play. Now normally antidiuretic hormone does what? Antidiuretic, so it prevents you from peeing, right? So why do we have this hormone? When does it get stimulated? Hypovolemia, right? So if you want to try to hold on to more water to try to, keep the hoses filled, so to speak, in terms of the vasculature. When else do we see that? Why would you see it in a fight or flight response? Yeah, you probably don't want to be peeing, right? Also, you want to keep your blood volume up, so that way you have enough blood pressure to perfuse all the organs and the muscles you need to, right? Yeah, so there's a couple other places we're going to see this actually occur here, but it's important to know that ADH is really important because it only affects water reabsorption, okay? And so you'll see there's a couple medications we have that directly affects the system here. Does anyone know, or I've probably mentioned this before, anyone know why drinking alcohol causes you to urinate so much? Actually inhibits the release of ADH. So whenever you hear someone breaking the seal, so to speak, that's what it is. Basically the ADH is being inhibited, so now you don't have that anti-diuresis effect, and so you diurese a whole bunch, right? So that's why people end up getting really dehydrated and they get a lot of really nasty headaches because of that, is based on the effect of alcohol on ADH. But this is where we're going to find our potassium sparing diuretics have a big effect here. Frequently when you want to reabsorb a lot of sodium in the collecting duct, you do so at the cost of potassium. And so you lose a lot of potassium, that's how you can develop hypokalemia, but this is where potassium sparing diuretics work, and they do that by holding on to more potassium and losing sodium, as we'll see in just a little bit. So this is the general idea of how you're going to see the nephron working, and now you kind of see where the different sites are going to be, where the different diuretics are working at, okay? So first off, let's talk about our loop diuretics, because these are going to be most likely the most kind of powerful out of the bunch. If Dr. O talked about using loop diuretics anywhere, what do we use it for? If you have like edema, you want to get rid of extra fluid, this is a good spot. What else? Heart failure is a big one, right? Because they have a pump problem, so they're holding on to a lot of volume. So it's another good place to get rid of fluid. Anytime you need to get rid of excess water, this is a really good class of drugs to do that with. And so we have a couple of different agents here. We have things like furosemide, we have bumetanide, we have torsemide, and then epicrinic acid, because it just wanted to be a little different. These are all going to be our loop diuretics. Okay. So anyone know why you call furosemide Lasix? You know where that name comes from? It lasts about 6 hours, which is interesting. So if you ever look at the dosing, now you know why that is. So if you see like QID dosing for Lasix, that's why it is, because it lasts about 6 hours or so. Anywho, again, you guys are getting more wowed by my random pharmacy facts, showing there's probably like a really, it's like Stockholm Syndrome, where you start to like sort of identify with your captors a little bit. So the jokes only get funnier from here, only because your mental decline is hastening. So anyway, don't ponder that too much. But so the loop diuretics here, so very powerful diuretics working in the ascending portion of the loop of Henle. And basically, normally what you would see, so here we have the interstitium side, here's where the blood's flowing, here's where you see the luminal side, or where the urine is at. Basically, this transporter here is responsible for absorbing sodium, potassium, and 2 chlorides, right, to kind of balance that out. So normally you would see this reabsorption occur here. There's going to be some sodium-potassium pumps that are also going to be at play to kind of balance things out. However, what you're going to find is with a loop diuretic, basically you're going to inhibit this pump here, okay? So the sodium, potassium, chloride pump gets inhibited. So what do you think happens at this point? Where does all that sodium, potassium, chloride like to hang out when you do that? It's going to stay out in the luminal side. It's going to stay out in the urine. So what does that do to water? It's going to follow all that salt, and then eventually gets out through the urine, right? So again, this is why it's so powerful, because it has a big effect on blocking the reabsorption of both sodium and potassium here. So what sort of side effects do you think you could see because of this direct mechanism? Dehydration, sure. What else? Hypokalemia, right, because you're losing potassium there. And what else? Hyponatremia, potentially, right? So these are all things you could expect to see just based off the mechanism of the drug itself, and that kind of makes a lot of sense. Again, if you know the background physiology here, if you know it really well, you can understand why a lot of the effects with the drugs we're going to see, why they happen essentially. And so as I mentioned, major effects here are going to block reabsorption of sodium and chloride by about 20 to 25%. This means you can increase urine output up to like 4 liters a day. So you can get a lot of heavy diuresis out of this. Very, very handy from that standpoint. You're also going to be losing potassium. In addition to that, you're also going to be losing calcium and magnesium excretion as well. So you can get hypomagnesiemic, you can get hypocalcemic potentially, hypokalemia, a lot of electrolyte imbalances. Now, why do we care about electrolyte imbalances in patients getting Lasix? They probably have a lot of heart issues as well, right? And if you cause imbalances there with the electrolytes, what do you put your patient at risk for? Arrhythmias, right? So again, this is why it's so important. And actually, one thing I'll tell you right now, I harp a lot on, is how these different medications are affecting electrolytes, because you need to know if my patient has a potassium of 6, which medications are potentially really dangerous to give to them, right? My patient's potassium is 3. What might be a really dangerous medication to give to them? What could exacerbate that? And those are the things they kind of want you to know, okay? Because there are very common adverse drug reactions that we see, especially in the hospital, in the ICU. Very frequently, we spend a lot of our time just chasing electrolytes and making sure that we're balancing everything out to prevent things like arrhythmias from developing, okay? Anyway, so what are some other things we can end up seeing here? We can see things like hyperglycemia, and you're like, well, why would you see hyperglycemia as a result of a loop diuretic? A lot of it is due to these compensatory mechanisms here. So for instance, one thing you can see is that hypokalemia itself can inhibit insulin release from the pancreas. That's one thing. However, also, it's part of those reflex mechanisms. So if I increase water flow through the kidneys, and I'm eliminating all of that, what do the kidneys detect? What do they think? Yeah, low volume. There's not enough volume here, so it's going to stimulate what system? Renin, angiotensin, aldosterone system, which also helps to stimulate the sympathetic nervous system. So when you have that occur, you're going to find that alpha-2 receptors get activated in the liver, in the pancreas, and then beta-2 receptors actually get stimulated in the liver. So that can cause glycogenolysis to occur, and then what occurs after that? You break down glycogen stored in the liver, and then you get, what's that process called? You get glycogenolysis, and then gluconeogenesis, right? So again, you have to have the two paired together. So you break down glycogenolysis, and then you get gluconeogenesis out of that process, right? So again, that's through those beta-2 receptors there. So that's why you end up seeing that not only are you not having enough insulin being released, which causes blood sugar to go up, but also you're stimulating new glucose to be produced from the liver itself. And then also just this can induce some degree of insulin sensitivity, or resistance, out at the periphery. Other things you're going to find here is that you can see some systemic vasodilator sort of actions here, and a lot of this is due to prostaglandins. Okay. Now, one thing I'm going to note, and I'm going to do some drawing here, so I apologize beforehand for having to see my poor art. But one thing I'm going to note here, and this is going to be responsible for a lot of drug interactions, and it's important to kind of get this concept down now. So let's say, for instance, we're going to talk about our glomerulus, right? And again, you may think this looks like maybe a uterus with like some fallopian tubes, perhaps. But let's say this is a glomerulus, right? We're just going to go with that. Now, this is blood flow coming into the glomerulus, right? And this is blood flow coming out. Okay. So these are arterioles. One of these is going to be the afferent, one's going to be the efferent. Which one's the efferent? Blood coming out, right? So this is going to be the efferent arteriole, and then blood coming in is going to be the afferent arteriole, okay? Now we can affect how much blood is actually getting to that glomerulus by affecting a couple of things. One, we can go ahead and affect how dilated the afferent arteriole is. If it's more constricted, what does that do to flow? It's going to decrease it, right? It's kind of like pinching off a hose. And then if I dilate it, I can increase GFR, right? So for instance, if I have hypovolemia, that can be a problem, right? Because obviously I'm getting less filter pressure, the volume's going to be down. Sometimes you'll have things like prostaglandins get produced to try to dilate that to get more volume heading into that glomerulus, right? So there's different ways we can affect that. On the efferent side, what happens if I were to open up this arteriole? You decrease GFR. Why? There's less back pressure, right? So there's less back pressure on the glomerulus, so GFR goes down here. So we're going to see there's a couple of different medications that affect this. Anyone know what that is? Angiotensin II is going to be really responsible for affecting the efferent arteriole. So prostaglandins are big for the afferent arteriole to dilate that vessel, and then angiotensin II is going to be responsible for causing constriction of this vessel. Okay, so opening up the one end, blood coming in, and then clamping down on the back end is going to cause GFR to go up. If I do the opposite and I get rid of prostaglandins, that's going to constrict that vessel, and then if I were to say get rid of angiotensin II, that's going to cause that vessel to dilate, and that causes GFR to go down because I have less stuff coming in, and then I also have less pressure to actually cause that filtration to occur. Okay. Now, what drugs have we already talked about that cause prostaglandins to be inhibited or to prevent their synthesis? Aspirin, and also more broadly, your NSAIDs, right? Anything that's inhibiting cyclooxygenase. So this is why we talk about NSAIDs causing renal dysfunction. Some patients are really dependent on having those prostaglandins around to keep this vessel open, and when you give them an NSAID, you get rid of those prostaglandins and it causes that vessel to clamp down, which causes an acute decrease in kidney function. Now, healthy patients, I can give it to NSAIDs to them all day and it's not a problem, but someone who has, say, progressive kidney disease, someone maybe is dialysis dependent, these are patients who are going to have much stronger effects there because they're really dependent on that, the prostaglandins, okay? We'll talk more about angiotensin II effects a little bit later on. That's also why you're going to see the ACE inhibitors can cause renal dysfunction, and it's mainly due to the effects on the efferent arteriole. Okay, does that make sense so far? Keep that in the back of your mind because these interactions will come up again and again, and so it's something I frequently harp on. Anywho, so some other things, as I mentioned, due to the reflex actions, due to that volume depletion, you're going to see the renin-angiotensin system gets upregulated, see aldosterone gets upregulated, and also antidiuretic hormone. Remember, antidiuretic hormone specifically, how does it cause water reabsorption to occur? Those little aquaporin channels that will put on that luminal side and it will reabsorb all that water. So you're going to see these effects get upregulated when you have diuretics causing this increased volume depletion. And so again, that will limit how well these drugs actually work in terms of their antihypertensive effects. Very frequently you can start someone on furosemide and you're going to find that, yeah, the blood pressure will come down, but it's going to be short-lived. And then once these compensatory mechanisms kick in, you're going to see that it's not going to be that great in terms of its long-lasting blood pressure lowering effects. So these are not going to be great antihypertensives, but they're really good at getting rid of volume if that's what you need to do. Okay. Other things you're going to find is that you can decrease excretion of uric acid, but also you find that you get this concentrating sort of effect because by getting rid of all that extra volume, you see this contraction occur in terms of blood volume and everything gets more concentrated, which can include uric acid, which can lead to gout potentially, right? So these are things you want to be wary of, and that could be exacerbating these patients that are receiving any sort of diuretic. Obviously, these being the most potent, these are going to be most likely to see that effect occur. Okay, you also can get a mild metabolic alkalosis that can occur here, mainly due to increased bicarb reabsorption in the kidneys. So it's kind of a minor effect you're going to see. That's what we call a contraction alkalosis. So not only do you see more reabsorption of bicarb, but also because the blood volume is lower, everything gets more concentrated. So that's an alkalosis you can see because of that. You see a little bit more hydrogen ion secretion as well in the kidneys. You can see some hyperlipidemia effects, mainly due to that increased sympathetic action, mainly due to those compensatory mechanisms. And then again, here you're going to find that GFR can be affected pretty significantly by those prostaglandins, as we mentioned, but angiotensin II is going to be another big regulator here, and that gets upregulated when you have loop diuretics on board. Okay. Now, one special thing to note with these is that typically loop diuretics will still continue to work even if you have a patient with low creatinine clearance. Okay, that's going to be not something you see with every other diuretic we're going to talk about, but even patients that have really low creatinine clearances, loop diuretics will still remain effective in order to get rid of some of that volume. Okay. So what are we going to use this for? We can use it for pulmonary edema, we can use it for nephrotic syndrome, or maybe they've had a lot of protein losses and they can't regulate their plasma fluids quite so effectively anymore. They have ascites due to cirrhosis, they have hypercalcemia. Sometimes we'll actually give them saline, which saline is made up of what? Sodium and chloride and water, right? We can give them saline to help replace any sodium they're losing, but also that helps to get rid of extra calcium. So that's one thing we can sometimes use it for. And then mainly you're going to see it for heart failure, renal failure, just to try to increase urine flow. And again, as I mentioned, hypertension, not great in the long term. It's not something you'd use to manage someone chronically, but certainly for the volume issues, this can be useful. Okay. So adverse effects, we already talked about a lot of the volume depletion sort of reflex mechanisms we already talked about there, but certainly hypokalemia, hyperglycemia, these can all be issues for certain patients there. That contraction alkalosis I mentioned clinically doesn't really come up all that too often as being all that too concerning, but the hyperuricemia. And then other things you might also want to know is this can actually be ototoxic, right? So this can damage the hair cells, and so you got to be careful with patients who are getting like really high dose loop diuretics kind of long term, like you think about those ICU patients who are getting a lot of this stuff. They can see some ototoxicity, so just be aware of that. And then obviously hyponatremia can also occur here as well, just because of direct increased excretion of that. Now, some patients may have a bit of photosensitivity or a rash seen with loop diuretics. Even though some people kind of misclassify them as being a sulfa drug, they do have sulfur in them, but if you have a patient who has a bad reaction to something like bumetanide or torsemide, you can use ethacrynic acid as an alternative. This one is one that kind of avoids that sulfa moiety, and so that one would be safe to use in most of those patients there. Okay. And again, you can see some azotemia, mainly due to that contraction. The BUN is going to go up because of that. Okay. Does anyone call a bun? Don't do that. Don't do it. BUN, okay. I'm trying to save you that embarrassment now when you're on rotations, right? Someone will come up and the bun was 14, and you'll be like, no, get out of here. Leave for the day. Anywho, so as I mentioned, a lot of drug interactions you're going to see with this. So with NSAIDs, again, that can blunt that natriuretic. When I say natriuretic, what does that mean? Urinate salt, essentially, right? So you're getting rid of sodium, and it can also blunt that blood pressure response, mainly due to the fact that when you get rid of those prostaglandins, you're decreasing the amount of flow coming into the glomerulus, right? So GFR is going to go down because of that. Aminoglycosides, we talked about those as being ototoxic too, right? And again, imagine a patient's in the ICU, they're being treated for, say, sepsis, they're getting a ton of fluids to help manage their blood pressure, you're giving them aminoglycosides to cover that Pseudomonas, and then you got to get rid of that extra fluid, so you give them Lasix, right? Now you can see how these drugs start to pile up. And again, if your patient's intubated and sedated, they can't tell you when they're having hearing loss, right? So it's harder to tell. Also, other things on here as well, lithium, which we use for bipolar disorder. Lithium actually looks a lot like salt to the kidneys, looks a lot like sodium, and so because of that, anything is causing you to try to hold on to more sodium, like that compensatory response we mentioned with the kidneys, you're going to hold on to more lithium. And so very frequently you can see patients will come in with lithium toxicity after starting a diuretic, or something like a loop diuretic. So one thing to note there. And then with digitalis or digoxin, you guys ever heard of that drug before? Might have mentioned it a few times. This one's really important. We'll talk much more about this when we talk about CHF, which I think is actually in the next test, thank goodness. But you can see some issues here where having hypokalemia, hypomagnesemia can really increase your risk for arrhythmia. So again, be really careful with their electrolytes anytime you're using these loop diuretics or really any diuretics. Okay, so any questions on the loops? Again, milligram for milligram, they're the most potent diuretics you're going to have in terms of volume off the patient. Okay, so very good for that. Now, getting into our thiazide diuretics, this is going to include chlorothiazide, hydrochlorothiazide, and a couple other agents, things like chlorthalidone, metolazone, and indapamide. Okay, so again, be nice if they all follow the thiazide naming convention, but it is what it is, right? So how are these working? These are going to be working in the distal convoluted tubule. So they're going to be working after the loop of Henle in the distal convoluted tubule. And so again, here with this picture, you can see the luminal side where the urine is, the interstitium side with the blood. There's a sodium chloride pump here, and this will be inhibited with the thiazide diuretics. Okay. Now again, you're going to find that the diuretic effect of the thiazides is going to be much less so than you would see with the loop diuretics. However, what happens if I put the two together? See any synergy there, you think? That's not the question, so presumably, yes, you would, right? Yeah, you can actually get pretty good synergy there. There's actually something called loop resistance that can happen. Sometimes what you'll see with patients getting loop diuretics for a while is that their distal convoluted tubule will actually try to pick up the slack, and they'll actually try to reabsorb more of that sodium and water. And so when you give, and you'll basically see the drug becomes less effective over time. If I add on a thiazide on top of that loop diuretic, guess what happens? Patient starts peeing again, just like I would expect with the loop by itself. And so it's called loop resistance. So you may see a patient on a thiazide and a loop diuretic at the same time, and that would be appropriate, right? There's good indications to do that in some cases here. Anyway, so this is the main action. It does have some carbonic anhydrase activity, which we'll talk about a little bit later on when we get into the agents that work in the proximal convoluted tubule here, and also a little bit of phosphodiesterase inhibitor activity. Anyone remember what phosphodiesterase does? Mentioned it briefly in pharmacodynamics. It actually has to do with our erectile dysfunction meds, but remember those medications actually blocked phosphodiesterase, which is something that broke down GMP, cyclic GMP. And so anyway, it has some vasodilator effects here. So this can also be useful for why the thiazides can be good for blood pressure potentially, right? Because it has some of that vasodilating action. It's a minor effect, but it could potentially be a little bit useful here. One thing to note as well is that any antihypertensive you can give to a patient, guess what is a potential risk for your male patients? Erectile dysfunction, right? That is a well-known thing because, again, if you're thinking about regulating blood pressure, regulating blood flow and things like that, you know, the body preferentially wants to perfuse which two organs? The head and the heart, right? So unfortunately, everything else takes a little bit of a backseat to that. So when you start to monkey around with the blood pressure, the body's like, well, that's not really so important, so we're just going to have, you know, just maybe it's not going to work quite so well. Not a big deal, right? To the guy, though, it may be a really big deal. So just note that any antihypertensive could induce erectile dysfunction in those males, so just be aware of that. Anyway, so our major actions you see with the thiazides is going to be increased sodium and chloride excretion. Now you will also end up seeing increased potassium and magnesium excretion. So you can see hypokalemia, you can see hypomagnesemia as a result of this as well. What's interesting though is you can actually get increased calcium reabsorption. So you're actually holding on to more calcium instead. So if there was a diuretic that could lead to something like hypercalcemia, this would actually be the agent that would do that because they block or they decrease the excretion of that calcium that cause more reabsorption of it to occur. When do you think this might be useful? Obviously, they have hypocalcemia. That could be one thing. Is there any disease states where calcium is maybe there's too much of it out in the renal tubule or in the urinary system? Yes, you could see that, right? But what could that lead to if you have a bunch of calcium sitting out in the urine? Kidney stones. Yeah, actually, you can see kidney stones because of that. Basically, those calcium oxalate crystals and those calcium crystals, they precipitate out because the concentrations are too high, right? They come out of solution. Well, by giving a thiazide diuretic, I can actually increase reabsorption of that calcium and leave less of it out in the urine and hopefully decrease kidney stones. If you ever saw like a relatively young patient who was on hydrochlorothiazide, it may not be because they have hypertension, but it could be because they have recurrent kidney stones. It could be one thing you might want to think about. And again, is this a problem in Florida? Yeah, we have a lot of calcium in our water, and so you end up, especially, I don't know if any of you had to grow up with like well water. It probably accounts for some of my mental faculties, but again, there's all kinds of stuff in well waters, like arsenic and lead and all kinds of bad stuff. But also a ton of calcium in the water here. So sometimes patients who come from out of the state that move here, sometimes they actually have an increased occurrence or new onset of kidney stones just because of all the calcium in the water potentially. So one thing to note. Anywho, other things you're going to see, a lot of the same compensatory mechanisms will be here, just like what we saw with the loop diuretics, including the hyperglycemia. The uric acid excretion can be a big issue, especially with the gout patients. And again, acutely, you can see a decrease in GFR, right? And why do we see that? blood volume's down, the renin-angiotensin system is going to be kicking in, right? And so again, acutely you can see a decrease in GFR, but you're going to find that it will then eventually regulate itself, right? Because we'll talk about kidney injury later on, probably next semester. We're talking about pre-renal, renal, and post-renal kidney injury. This is one of the pre-renal kidney injuries where actually you're decreasing volume, getting to the kidney, and that's hypoperfusing it. So that's one of the things you can see acutely. Okay, so what are we going to use our thiazide diuretics for? We're going to see this primarily being used for hypertension. Oftentimes it's not used by itself to manage volume and try to use it for directly as its diuretic effect, but occasionally you may use it in addition to like a loop diuretic for patients with like CHF or cirrhosis, things like that. And again, as I mentioned, to help out with hypercalcemia, well, it'll actually cause hypercalcemia, sure enough, but it will help to decrease those deposits of those renal kidney stones, mainly because you're getting less of it in the actual urine. Okay. So where are we going to be using this? Hypertension, as I mentioned, is going to be far and away the most common indication for our thiazide diuretics. It tends to work better in elderly patients and obese patients, black patients, and those that are sodium retentive. I mean, they're holding on to more sodium. And so it does this through a couple of different mechanisms here that's not directly related to its diuretic effect in the distal convoluted tubule. So a couple of things here. Short term, sure, you're going to decrease cardiac output and blood volume because there's just less volume there, but we mentioned that's a short-lived effect. The renin-angiotensin system really helps to blunt that because aldosterone's kicking in, antidiuretic hormone, those volume losses will be fixed essentially. What other things will it do? Well, it has some direct vasorelaxant effects, which can decrease your total peripheral resistance, right? So it helps to relax those vessels a little bit. You can decrease some of the sodium deposition in the actual vasculature, right? So it's called this waterlogging effect, where sodium kind of is being stuck out in the actual endothelial lining of the vessels, and that holds on to water too. So by getting rid of some of that, you're going to cause the vessels to kind of shrink down a little bit. They'll be a little bit thinner, and it'll be more able to hold on to that volume, right? So the pressure goes down because of that. So decreased wall thickness, increased diameter. That's where we're getting a lot of your benefit from a hypertensive standpoint. And then overall, you're going to see kind of less responsiveness to things like norepinephrine, which can also help to decrease that vasoconstriction effect. So typically, you're going to find that when you're using diuretics, typically low dose is where you're going to get most of your benefit. That's why you see patients on like 25, 50 milligrams of hydrochlorothiazide, and even going well above that, you don't get a whole lot of extra benefit. Mainly it's because you're looking for those antihypertensive effects, and that's where you're going to get them at those very low doses. So, as I mentioned, the volume depletion effects are going to be the big things you see there. Again, compensatory increases in blood glucose and your lipids can be affected here. But remember, these effects are going to be much more minimal as compared to your loop diuretics, just because their diuretic effect is less pronounced there. Okay. As I mentioned, hypokalemia, the hyperuricemia, metabolic alkalosis is all going to be present here as well. Okay. Again, hypercalcemia is going to be the one thing that's notable about the thiazides that is different from a lot of the other diuretics we're going to talk about. As I mentioned with loop diuretics, you're going to see hyponatremia, hypokalemia, hypomagnesemia, hypocalcemia. This is the one thing that's different, is you're going to see hypercalcemia with the thiazides. Okay. What's another big thing you can expect to see? Say you have like an old elderly patient here given a diuretic to, and say they take it, say in the morning time and at night time, it could be a potential problem for those patients. Why might they fall? Yeah, they have orthostatic hypotension, right? So blood volume's down. When they go to stand up, maybe they're going to have less blood flow getting to the head, which can cause them to be dizzy. They stumble and fall, like crack a hip or something. What else could it be a problem as well? Like say you're giving it around bedtime. Yeah, you have to get up and pee in the middle of the night, right? It's dark, you're stumbling around, you're already a little bit dizzy anyway from the orthostatic hypotension. That's where you can see those falls really being a big risk there. So that's something to always consider, is like, okay, what are the actual direct implications in terms of like my patient having to get up in the middle of the night to go pee a bunch? What effects might that have, right? Anyway, so we mentioned sexual dysfunction, constipation you can also see here as maybe due to some of the calcium effects you can see with that. And then one thing to note here is that thiazides tend to be ineffective at low creatinine clearances. Once you get it below, like say 30 to 40 mLs a minute, what's a normal creatinine clearance? Like 80 to 110, somewhere around there, right? So usually, in the close to 100 is usually considered a pretty good creatinine clearance. Once you get down below, say 30 or 40, it's pretty significant kidney dysfunction. You will find that most of the thiazides do not work anymore. However, there is one that does work. So metolazone is going to be remaining effective even at those low creatinine clearances. So if you had a patient who had kidney failure and they were really volume overloaded and you're giving them loop of diuretics, but it really wasn't doing enough work, you can add on metolazone and it will then increase urine outflow pretty well. I had a nephrologist one time that said metolazone can make a rock urinate. So that's pretty good. I always remember that. So even because again, how good is a rock's kidney function? Not non-existent, right? So if it can make that pee, then it's got to be pretty good. So that's how I remember that. Anywho. So getting into drug interactions, as I mentioned, the NSAIDs will blunt the diuretic effect of the thiazides, mainly due to the same actions we talked about in terms of the prostaglandin synthesis. That's going to cause that afferent arteriole to constrict with the lack of prostaglandins. And again, you can find a big issue with digoxin for the same reasons as the loop diuretics. Okay. What's a normal potassium level? 3.5 to 5 is generally considered normal. However, wherever you go to work, you'll find that it may have different allowances on that, but I usually think 3.5 to 5. What's a normal sodium? 135. Yeah, 135 to 145. Yeah, very good. Yeah, so 135 to 145 is a normal sodium. 3.5 to 5 is a normal potassium. You'll kind of get these as you go along, and you see it more, you'll know what is considered normal. How about a bicarb? I usually use 21 to 28, somewhere around there is pretty good. How about normal serum creatinine? That one's a little more variable, but I usually think like 0.6, maybe like, maybe close to 1, depends, very patient dependent in a lot of cases. Anyway, I'm just trying to pimp you a little bit, you can kind of keep these things in the back of your mind. Anywho. Okay, so let's talk about our potassium sparing diuretics. What do you think these are going to do? Spare potassium, right? So you'd expect to see what? Electrolyte imbalance? Hyperkalemia, right? Could be a risk, could be an issue here because you're sparing potassium, right? Essentially what this means is, so imagine we're looking at the collecting duct specifically. You're going to find that here we have the luminal side again, here we have the interstitium side. There's going to be a couple different things playing a role here. So for one, we have antidiuretic hormone, which is going to be stimulating these aquaporin channels that get put into the luminal side, right? So it's only going to reabsorb water. So not really important for our purposes right this second, but I just want to give you an idea kind of what else is going on here. What you're going to note, though, in a lot of cases that things like aldosterone are going to stimulate sodium reabsorption, but at the loss of potassium, okay? So normally if you're someone who has hyperaldosteronism, what sort of electrolyte imbalance do you expect to see with them? You get hypokalemic, right? So they're losing a lot of potassium when you have all that aldosterone activity going on, which again is upregulated when the renin-angiotensin aldosterone system is upregulated, okay? So anyway, a couple different things we could do. One, we could block this transporter here and block that sodium inflow, which will cause us to hold on to more potassium. That's one way we could do it. Or we could block the effects of aldosterone altogether. So there's going to be what we call aldosterone antagonists that we can also use, which we'll talk about in a few moments here. Now again, in terms of how well these are working, how do you think they stack up in comparison to like our loops and our thiazides? Pretty strong or pretty weak? Pretty weak. They're already working at the tail end of the system anyway, right? So they're working at the collecting duct, maybe a little bit the distal convoluted tubule, but mainly the collecting duct. And so because of that, these are going to have very minimal effects. However, what's a big side effect we talked about the thiazides and the loops causing? That may be important here. They cause low potassium and they cause hypokalemia, so this can offset that quite a bit. And so this is frequently why you see combinations of, say, a loop diuretic or, say, a thiazide diuretic plus a potassium sparing diuretic, right? They kind of offset one another such that the potassium level will hopefully stay somewhat normal, right? Does anyone know how much potassium is in a banana? Something I heard was there's roughly, for every square inch of banana, you get 1 milliequivalent of potassium. Right? They try to keep it easy, right? It's probably not exactly that, but it's close enough to remember that. So if anyone's ever like, my patient's hypokalemic, and you tell them, like, go eat a banana, they have to eat like a pretty long banana in order to fix that, right? If you imagine giving 20 or 40 K of potassium, or milliequivalents of potassium, it's a long banana. I don't think most places carry those. So anyway, just again, a little bit of trivia. So note here, so there's a couple of different mechanisms. As I mentioned, you can either block the sodium transporters, and this is going to inhibit both sodium-calcium antiporters and the sodium hydrogen ion antiporters here as well. And so overall, it's going to inhibit maybe 2 to 3% of sodium chloride reabsorption, pretty weak in comparison to, say, the 20 or 25% we saw with loops, the 5% we saw with thiazides. However, you're going to be seeing less of this potassium excretion happening here, so you'll hold on to more of it, and so that's why it's potassium sparing, okay? So a modest increase in urine flow, but not going to be nearly as potent as you would see with the loops. So a couple of drugs here you're going to find include amiloride or triamterene. Now again, you're going to find patients using loop diuretics all the time. You're going to find patients using thiazides all the time. These are going to be less used. So they're still, you want to have them in the back of your mind in terms of like one of your, the options you have available to you, but just know they're not used quite so frequently. Usually not by themselves. They're very frequently used in addition to hydrochlorothiazide. So most often as an antihypertensive, using it to offset the hypokalemia that the HCTZ can end up inducing. Same indications here as the other diuretics you're going to see, and most of the same side effects, with the one notable exception being hyperkalemia being the big thing you're going to see with that potentially. So you have to be really careful because there's other medications that can also affect your potassium levels. So if I had something that maybe inhibited the activity of aldosterone, what would that do to my potassium levels? It's going to cause them to go up as well, as I just mentioned. So this is where things like ACE inhibitors and angiotensin receptor blockers are going to be able to raise potassium levels. If a patient's taking a potassium supplement, because say for instance they were on a loop diuretic long term and they were trying to, they were prescribed to take a potassium supplement on top of that, and then you add this drug on without realizing they're taking that supplement, you can cause some big issues there in terms of potassium becoming too high. So just be aware of that. Also, one thing to note is you can see this megaloblastic anemia with triamterene. Again, not a clear mechanism for that. Maybe inhibits absorption of maybe some B12 or folic acid or something like that. But that is one thing that is notable with this one. And some azotemia with amiloride. But again, you can see that anyway with diuretics, just do that contraction sort of effect. Okay, so along the same line as the aldosterone, or I'm sorry, the potassium-sparing diuretics are also going to be our aldosterone antagonists. And as I mentioned, normally, and I'm sorry that my picture is kind of covering up the text here, but basically, aldosterone itself is a hormone, right? You're going to find it kind of works just like a steroid would. And if you recall, there's kind of two main bifurcations of steroid effects, right? We have the glucocorticoid effects, and we have, what's the other one? The mineralocorticoid effects. And what's the primary mineralocorticoid we produce? Aldosterone, right? And again, it's called mineralocorticoid because it has to do with minerals or salts, right? So this is where it has big effects to cause increased uptake of sodium from the urine. But again, it's at the expense of potassium. So by giving an aldosterone antagonist, what would you expect the potassium levels to do? It would go up, right, because you're holding on to more of it because you're blunting that effect here. So you could have something like triamterene or amiloride directly affecting the sodium transporter, but I could also have a drug come in and block the activity of aldosterone altogether. Okay, so again, you can see a little bit of synergy there. So you're going to find there's going to be an increased number of, normally when aldosterone binds, you're going to find an increased number of sodium channels here, but if I get rid of that, you're going to find less sodium channels, less sodium reabsorption, and thus less of that potassium being excreted. So we have two drugs that fit in this category. We have spironolactone and we have eplerenone. Now, spironolactone has some other interesting effects as well, which we're going to see in like dermatology. This will come up briefly. We'll see this come up more so in CHF. These are mainly drugs that are going to be used for that patient population that has CHF for the most part. But we have two here. We have spironolactone and then we have eplerenone, aldactone and Inspra respectively. So what's interesting is because they are basically blocking the effects of aldosterone, they themselves can have some interesting effects in terms of affecting other sorts of hormone receptors. And so one of the big things you're going to see with spironolactone is actually going to be a partial agonist at the testosterone receptor. So it's a partial agonist at the testosterone receptor. What sort of effects could you see with that? Or something. So yeah, so decreased testosterone effects in patients who have high testosterone levels, so generally your male patients, right? So maybe you're blunting that, so what could you see in those male patients? Gynecomastia, that's a very classic sort of side effect of spironolactone is gynecomastia, right? You see other things as well, you can see testicular atrophy potentially, things like that. What would happen in a female patient who is receiving spironolactone as a partial testosterone receptor agonist? So for them to have relatively low testosterone activity, you'd actually bump it up a little bit by having that partial agonist. So you can actually see things like hirsutism, voice deepening, things like that. And again, a lot of it is dose dependent. So just be aware of the effects that it can have in terms of its testosterone partial receptor activity there. But anywho, what you're going to find here is that it's going to be working at the site of the nucleus, just like other steroids we've already talked about, like your glucocorticoids, like prednisone and things like that. You're going to find that this is going to be most effective when your aldosterone levels are high, because obviously if there's more of it being expressed, you're able to inhibit it better. Otherwise, if you had relatively low levels of aldosterone being expressed, the drug could be inhibiting those receptors, but doesn't really do anything to the baseline level of activity. They're going to have minimal effects on sodium chloride reabsorption there. You'll see maybe 2 to 3%, but the big thing is it will hold on to that potassium. Okay, so this means that if you have a patient who's already hyperkalemic, this is going to be a no-go. You don't want to use these medications. But if you have someone who's taking a loop diuretic or a thiazide, this might be a good drug to add on potentially. Okay. And again, we'll use this if a patient has primary aldosteronism. Maybe they have a tumor secreting it. Maybe they have some other reason for having primary aldosteronism. We'll do this for hypertension. And then one of the big places we'll talk about is going to be in CHF. And it's actually been shown to have some degree of mortality benefits if you give it to really late stage class 4 sort of patients with CHF. Have you covered CHF yet? Yeah, so we'll get that a little bit later, probably on the next test, so just going to keep that in the back of your mind. But again, it can be useful as an adjunct to something like a loop diuretic for those edematous sort of conditions. Again, adverse effects you're going to be seeing hyperkalemia, maybe a mild acidosis due to the fact that it's going to have, and blocking the, it's going to actually cause reabsorption of more hydrogen ions, so that is one thing to note there. And then as I mentioned, the weak androgenic effects can cause things like gynecomastia and testicular atrophy in male patients, but it can cause menstrual irregularities and hirsutism in females, because again, they're at a relatively low resting testosterone level anyway, and then this will then bump that up to, for those effects there. Typically, a plurilinone has less of those effects, so if you had a patient who's getting spironolactone, had gynecomastia, it could be reasonable to switch them over to a plurilinone. It is newer and more expensive, so that could be one downside to it. All right, and then I'll just kind of finish up with the diuretic before I let you go on break. So we have the carbonic anhydrase inhibitors. What do you think these drugs do? Inhibit carbonic anhydrase. Perfect, good job. We've covered these before, right? Where else do we see these? In ophtho for glaucoma, right? Remember they prevented the formation of bicarb essentially, right? Because carbonic anhydrase normally will convert H2O and what else? CO2 into bicarb and vice versa, right? And so based on that, normally bicarb can't really cross those membranes all that too easily, and so what you find is that when you inhibit that enzyme, you end up causing bicarb to kind of be stuck on one side or the other. And so in these cases, we mentioned that normally bicarb gets filtered freely through the glomerulus, but where does it get reuptaken at? Usually in the proximal convoluted tubule, right? So you're causing, you have the uptake there at the proximal convoluted tubule. Well, if I inhibit that process and I inhibit carbonic anhydrase, guess where all the bicarb is stuck? In the urine, and then guess where it gets eliminated? Through the urine, right? So if I were to say do a urinalysis on a patient who is receiving one of these drugs, their UA, the pH would look high or low? It would look high because they have all that bicarb they're secreting out through the urine, right? If I did an ABG, an arterial blood gas, what would that show? They'd have a mild acidosis because they're peeing out all their bicarb, right? Again, where are the two big places that we regulate pH in the body? The lungs and the kidneys, right? Which one's kind of faster at regulating that? Lungs are much faster, kidneys are going to be for more long-term sort of changes there. But if I'm blocking sodium bicarb, or just bicarb from being reabsorbed in the renal tubules, you find that it gets peed out, so you can cause a non-gap metabolic acidosis. That's something we'll talk about in just a moment here. Now, normally when I say gap, what does that mean in terms of? Yeah, anion gap, right? How do you calculate that? Sodium minus bicarb plus chloride, right? And what's like a normal gap? 8 to 40, yeah, somewhere. So I usually will say anything greater than 10 I usually consider to be abnormal. That's when we want to start kind of investigating a little bit to see if anything is going on there. Certainly if it's above like 16 or something, like that's where I'm getting a little more concerned. What's interesting though is you actually find that the chloride actually increases to offset the bicarb, so they get what they call non-gap acidosis. So even though you're losing the bicarb, there's enough chloride around there that actually the anion gap stays normal. So in those cases there, we call that non-gap acidosis. You can actually see that. I remember I had one patient who had overdosed on a drug one time. It was called topiramate. Anyone ever heard of Topamax? It's used for sometimes like for migraine prevention. It's a seizure medication. They actually overdosed on it, and it has weak carbonic anhydrase effects as well. And so we're looking at the ABG. We're looking at the basic metabolic panel. We're just like, why is the bicarb so low? Like, what's going on here? We did the anion gap, and it was negative. We're like, what the heck is going on? We looked it up, and sure enough, it was the actual drug that caused that itself, right? Anywho, again, not that interesting of an anecdote, but it does happen. So again, you're going to see decrease in reabsorption of bicarb. You're going to lose a little bit of salt along with that as well. However, what do we say about sort of the effects of a diuretic working so early in the proximal convoluted tubule? Yeah, loop of Henle is going to be able to offset that quite a bit. And so you're going to see these are probably the mildest sort of diuretics that we have out there, and we don't use them very often clinically for their diuresis-inducing effects. We don't really use them a lot for their effects on, say, hypertension, things like that. However, we did see we could use them in the eyes because it actually helped to increase what? or decrease the production of the aqueous humor, right? So that's one thing we can do. Also, it actually has a big effect on CSF. So we'll talk about why that is in just a moment. So 3 drugs we have here, including acetazolamide or Diamox. This is probably the most common one we're going to see there. Dichlorphenamide and then methazolamide are going to be the other 2 there. But I'll tell you, the only one I've ever seen clinically is usually acetazolamide. So looking here, if you're looking at the proximal tubule, you see here the luminal side, here's the interstitial side here. Normally carbonic anhydrase would then convert bicarb that gets filtered through the glomerulus, so break it down into CO2 and water, which is very easily reabsorbed, and then carbonic anhydrase can convert it back over into bicarb. Here, when you're blocking this process, all the bicarb just stays out there in the luminal side and just gets eliminated in the urine. It'll pull a little bit of sodium along with it, and that's where you get some of that mild diuretic sort of effect. So we mentioned decreased bicarb transmission in the eye and the ciliary body, so that's going to decrease aqueous humor production. We already talked about that. But interestingly enough, this can be useful for some other things. So as an example, for epilepsy, right? So you think, well, why would this be good for epilepsy? One of the things you find is that patients who have a lower pH, so a little bit more on the acidotic side, they actually have a higher seizure threshold. It is more difficult for them to have a seizure when they're in a little bit more of an acidotic state. So how could I do that, right? Well, there's a couple of things I could do. One, I could give them a drug that increases bicarb excretion. That puts them in a slightly more acidotic state, and thus they will have a harder time having a seizure potentially, right? What's another way I could do that? Maybe with diet. Is there any diets that give you an acidotic state? Yes, a ketogenic diet. Yeah, so there's actually ketogenic diets. We'll put patients on, once they've failed like 4 or 5 different seizure medication therapies, we'll actually put them on a ketogenic diet potentially, and they're getting very, very low carbohydrate intake, and that actually puts them in a state where they're oxidizing fatty acids in the adipose tissue, and that produces a lot of ketone bodies and things like that, and it puts them in a slightly more acidotic state such that they're having a harder time having a seizure, right? That's really important in pharmacy. What do you think that is? Imagine like a little kid who's coming in, they don't take tablets, they're only taking liquid medications. What's included in a lot of those liquid medications? Sugar, right? You put a lot of sugar in those things. Or think about IV fluids. You put them on D5 water, guess what? That's all dextrose. It gets converted into glucose. So again, those are little things we think about. We'll talk more about that in the neurology section later on. But again, this is another use for this medication here. Now, mountain sickness. Why do you think this could be good for mountain sickness? What is mountain sickness? It's like you go up to Appalachia and have a little bit too much of that moonshine and get a little sick. No, it's not that. No, it's basically we're into finding that as we increase in altitude, hopefully I don't butcher this, I haven't gone over the pathophys in a little bit, but let's say we're going to go up in altitude. We go from here, let's say, to Denver, Colorado. Okay, how high is Denver, Colorado?
Mile high.
Mile high city, right? So it's a mile high. Has anyone made that trip and then try to like go up like a set of stairs? What happened? You're just like, well, why do you see that? The partial pressure of oxygen is lower the higher up in altitude you go. So you're inhaling all this oxygen, but there's just less of it there, right? So you get very out of breath very quickly, and your body's not adapted to that, right? So there's a couple different things that go on to help you to do that. However, we can actually fix that with medications. Actually, I had a friend that went to Peru one time to go hiking there, and he did this exact thing, where basically they're going to go up quite a bit of ascension, and in order to combat that decrease in oxygen, well, what could we do? Well, we can actually induce tachypnea in our patients to breathe in more oxygen. The way we can do that is to put the body into an acidotic state with this medication there, and what does your body do to compensate for that? It says, well, I got to breathe off that CO2, because I'm acidotic, so it wants to breathe off CO2, and so in doing so, you're breathing in more oxygen, right? So you kind of induce this mild tachypnea in order to, also it helps with the oxygen hemoglobin desaturation curve. You guys covered that before? Yeah, probably looked at it. Yeah, it's going to be shifting over such that when you're in a more acidotic state, you're going to be dropping off more of that oxygen to the tissues, such that when you climb up the stairs, you're not huffing and puffing like crazy, like I was when I went and tried to climb a set of stairs. And I said, you know what? Escalators are a good thing, and I'm going to keep using these instead, right?
So you just pop one of those when you go to Colorado? Is that what you should do?
You know, so if you develop that mountain sickness, right, so you're developing like headaches and nausea, vomiting, things like that, what you can do is take this for usually like 24, 48 hours beforehand, and then you would take it until basically you're at the same level for like 2 or 3 days or so. You can just kind of, and then you can stop taking it. Because then your body's going to compensate for that, so things like hemoglobin will start to go up, and your body has some other processes that helps with that. That's why like a lot of athletes will go up to high altitudes to train, because it actually increases their hemoglobin. It's kind of like their blood doping naturally, and they come back down and can perform a little bit better at kind of ground level, right? I like to do that like before a Fortnite tournament or something. I'd be like going up to like really, because I mean, I get this finger, it's got to be clicking fast, in order to. I'm just kidding, I don't play Fortnite. Did someone say, what's Fortnite? Studying too hard, I appreciate that. Good job. Anyway, so what you can expect to see in terms of other actions here is metabolic acidosis. Again, it's kind of mild. It's that non-gap acidosis you expect to see there. Some potassium depletion and maybe a little bit of drowsiness, and that's due to some of the CNS effects you can see. I forgot to mention on that last part, the head injury, you can actually decrease CSF production the same way that you decrease aqueous humor production with these things. And so occasionally if you have a head injury and you had swelling that was occurring there, this could be sort of a minor way to help out with that. It's not going to be the thing to fix the patient by any means, but it could be something that can help. Yeah, CSF production would actually go down there, mainly due to those bicarb effects. So, any questions on the diuretics? Hopefully most of you need to go to the bathroom now, because we've been hearing about it so much. I'll see you in 10 minutes. So, the question, what medications can be given to treat arachnophobia? Xanax is pretty good, yeah. Yeah, healthy dose of benzos, vodka, I mean, any of those things good. It's true, it works. Actually, benzo and alcohol, the same exact mechanism, essentially, right? So. We'll talk much more about that later on. Not like at the bar, but I mean like in a later lecture. Neurology. Anywho. Okay, so any questions from the first half? I'm feeling pretty comfortable with their diuretics. We're going to have a good bathroom break, hopefully. Never appreciated all that urine you produce. It's a very complicated system, as it turns out, right? A lot of ways we can affect that. Anywho. Getting into the renin-angiotensin-aldosterone system, we've been alluding to this quite a bit. You've covered it previously, so I'll just kind of briefly mention some of the effects we're going to see here. So one, it really helps out with blood pressure regulation. Angiotensin II normally has what kind of effects on the vessels? Vasoconstrictive, right? It's a very potent vasoconstrictor. So right there, you're already increasing blood pressure. Also, you're going to see that more secretion of aldosterone occurs because of this, which causes blood volume to go up, right? Because we already talked about that, holding on to more sodium, holding on to more water, those effects there. So you're getting a lot of kind of compensatory effects here to get that blood pressure up. You're also going to see some CNS effects in terms of antidiuretic hormone being stimulated here. When you have a lot of antidiuretic hormone being released, what do you want to do? Like the most, like the one thing you want to do more than anything else, you're in a hyper ADH secreting state. You get a drink of water, right? You get a lot of thirst response related to that. You guys know what they call the disease you get when you have too much ADH being secreted? That's actually the blocking of ADH. If you're releasing too little, or if your kidneys are not responding to it, as diabetes insipidus, you end up peeing out a ton of volume. This is SIADH, which is a syndrome of inappropriate antidiuretic hormone secretion. And so you can get that from tumors, you can get it from head traumas. I remember when I was on rotations, I was rotating in a surgical ICU, so you get a lot of people with like head traumas after a car accident. And this one lady had really bad SIADH, and so she was hyponatremic because of it, because of the effects that ADH had on the kidneys. And so she's secreting a lot, she's holding on to a lot of free water, but not a ton of sodium, so she's hyponatremic. And so, but it also triggers that thirst response. And so I'd never seen anyone want a drink of water so bad, like Gatorade, water, anything they wanted. They would try to bribe family members who were visiting them, the nurses. They would try to sneak out of the room to go to the cafeteria because they were on a strict water restriction, because more water coming in would do what to their sodium level? Would drop it even more, right? So again, this is a very interesting patient just because the behavior was so interesting, and it's due to this one hormone being out of whack. So. Anywho, but it's some things you can see there. Obviously, the autonomic nervous system is going to be impacted as well. Mainly, the sympathetic nervous system is going to be kind of activated, and then we'll see what these kind of angiotensin systems look like. Now, normally, you're going to find that the kidneys are going to be secreting renin, and when do they decide to do that? Yeah, usually if they're like in a low volume state, or they detect they're not filtering enough water or salt, typically. And again, what is the thing that normally detects that? The juxtaglomerular cells and the macula densa, right? Those are really important for trying to detect the sodium coming through the kidneys. And they say there's too little, and they're going to say, okay, let's go ahead and increase this renin-angiotensin system to activate. So they're going to release more renin. This will then cause a conversion of angiotensinogen over to angiotensin 1. And then this is where I really care about this, because this is where a lot of our meds are going to work, is this ACE enzyme, right? Angiotensin converting enzyme will convert it from Ang1 over to Ang2. Ang2 can then go and affect the adrenal cortex to release aldosterone. It will also affect the arterioles to cause vasoconstriction. Okay. Now, what type of receptors are they going to be hitting? Angiotensin 2 would affect what type of receptors? angiotensin receptors, right? It's very straightforward, right? So I'm trying to make it easy on you guys. So angiotensin receptors are going to be there, because remember, we have our ACE inhibitors. What's the other class of drugs that do the same thing? ARBs, and those are angiotensin receptor blockers, right? Anyway, so they're going to go on and then affect these receptors, ARBs, or the angiotensin receptors downstream here. Also note as well that when you have angiotensin converting enzyme, it is also responsible for metabolizing this product called bradykinin. It's covered what bradykinin does. I think I have some vasodilatory sort of effects here. Some people think it has to do with some of the allergies you can find that can develop as a result of interacting with the system here, but we'll cover that in just a little bit. But that's kind of the main thing we're going to see here. And again, not only is the macula densa and those juxtaglomerular cells playing a role here, but also the renal baroreceptors. Baroreceptors means what? Detecting pressure, right? So they detect low pressure, that will then stimulate that to occur, and that's usually due to low volume. And then the sympathetic nervous system will also help stimulate this. So if you're in that fight or flight response, again, you're going to be saying, hey, I don't want blood volume because I want to be able to perfuse my muscles so I can run away from whatever aggressor is coming at me, right? Whether it's a bear or an alligator. Or, these are things I think are common occurrences apparently, but it can happen out here. You see alligators all the time. Or snakes, perhaps. Who knows? Anywho. Or spiders, as it may turn out to be. Right. Anyway. So, as we mentioned, when you have decreased renal perfusion, renin level is going to go up. When the macula densa detects there's low amounts of sodium being filtered through the nephron, that's going to also kind of uptake this renin release here. And as I mentioned, the SNS, when you have a lot of those things like norepinephrine being released from those neurons, you're going to be seeing this. It will also stimulate renin release as well. Now, angiotensin 2, as I mentioned, is a strong vasoconstrictor. It'll stimulate aldosterone to be released here. It'll also cause renal vasoconstriction, right? Now, this is important because which arteriole did it affect? The efferent, right? It's going to cause constriction of the efferent arteriole, which does what to the glomerulus? Increases filtering pressure, right? So GFR goes up when you have, presumably, angiotensin 2 causing that clamp on the system, right? So it's kind of like putting your thumb partially over a hose. What do you know about the pressure? Sprays out everywhere. My kid just figured that out, my 3-year-old, and so we spent all weekend being soaked, which was super fun for her, not for me, but whatever. Anywho, actually, just a funny aside with working with 3-year-olds and watching their little brains develop. She associates anytime something's like not working or something hurts or something, she says it's broken. So like she like stubbed her toe. She's like, oh, my toe's broken. And it's like, well, not really, but anyway. So one time I had given her like some mac and cheese or something. It was like slightly too hot. She was like spitting it out everywhere. Goes, my mouth is broken. Oh, not really, but calmed her down. And then my wife unfortunately got while she is perfect, she unfortunately developed a blemish on her face. And then the 3-year-old, what did she come up and do? She says, Mommy, your face is broken. I was like, kid, no. You got some lessons to teach you. Anyway. So getting onto this. So as I mentioned, renin release, again, causing a lot of vasoconstriction. Normally GFR is going to go up when you have that constriction on the efferent arteriole, so be noticing that. Again, when you interrupt the system, when you have something like an angiotensin converting enzyme inhibitor, you're going to see what effects that's going to have on the kidneys. And so that's one of the things you always hear is that, giving an ACE inhibitor to certain patients can cause kidney failure or kidney injury. This is why, because you're interrupting this angiotensin 2 constriction on that efferent arteriole. Okay. Other things you're going to see increased norepinephrine release, which what does norepinephrine release do to blood pressure? It increases it, right? Because it affects what type of receptors? Going back to the physiology lecture I gave at the end of pharmacodynamics, some of those are going to be important, as you'll find. Alpha-1 receptors, right? Alpha-1 receptors cause vasoconstriction, right? Also, you're going to find the ADH release is going to be stimulated, so thirst is going to be up, so you're going to want to take in more volume in addition to holding on to more volume in the kidneys. And not only that, but this is also a really big deal in the long term. You have a patient who has myocardial ischemia. You have a patient who has CHF where the left ventricle is having to work too hard for too long. Angiotensin 2 is responsible for a lot of the remodeling that we see there. When I say remodeling, does it mean like putting up some new like lampshades, or what am I talking about? It's getting thicker and it's getting less compliant, and thus the pumping is not going to be any better, right? So one of the big things you're going to find is that when you give patients ACE inhibitors or ARBs, anything to disrupt the renin-angiotensin system, you're going to find you keep the heart working better for longer. You decrease that remodeling, and what do you think it does to mortality? decreases it, right? These are life-saving medications in the long term, right? We have really good cardiac studies, right? Remember that Framingham heart study? Like, these are the type of studies we're talking about that really show good benefits in mortality, right? People are living for longer when they have these medications on board. Anywho, as I mentioned, overactivity of this system, which a lot of our patients have, include hypertension, can worsen CHF by kind of hastening that remodeling of the left ventricle. Diabetic nephropathies can occur here, right? What do I mean by that? You're going to see that chronic long-term hyperglycemia can actually end up damaging the glomerulus, right? Imagine all that glucose kind of going through the glomerulus, kind of shredding it up. It doesn't work as well. And so one of the things you're going to find is that also by giving an angiotensin receptor blocker or an angiotensin converting enzyme inhibitor, you also can help to preserve kidney function for these patients for longer. So if you have like a diabetic patient, most of the time you want to put them on an ACE inhibitor because it preserves kidney function long-term, right? Because do the kidneys just magically regenerate themselves after time? No, they're not as cool as the liver is, right? Liver can regenerate practically anything, right? It's like a lizard tail or something like that. You cut it off, it just grows right back. Kidneys not so much, right? You can only slow down progression. You can't reverse the damage that's already done there. As we mentioned, also myocardial remodeling after MI. Once you have that ischemic tissue trying to recover from that, that's where you see a lot of scar tissue form, the remodeling that occurs, make it very fibrous and not very compliant there. So as I mentioned, anything that disrupts the system is going to have big effects on morbidity and mortality. So some of the physiologic actions we're going to see here. So we're going to see by inhibiting the ACE enzyme, you're going to have decreased angiotensin II vasoconstriction. You're going to see decreases in aldosterone. You're going to see less sodium reabsorption. You're going to find angiotensin II is going to cause less of that norepinephrine release to occur there. And not only that, but you will see a negative feedback loop being interrupted where your kidneys are going to try to release more renin to account for the fact that it has less angiotensin II working, but because you're inhibiting that enzyme, it doesn't really matter, right? It's very potent what it does to decrease overall angiotensin II activity. And as I mentioned, that bradykinin metabolism is going to go down. That'll be important for some of the side effects we're going to see here in just a little bit. Anyone know what side effect bradykinin causes? Possibly angioedema. We'll talk about another one that's more common and kind of bothersome to some patients, as we'll see. Anywho, so again, all the ACE inhibitors have the same exact mechanism of action. The only thing that differs really between them is going to be in terms of how they get metabolized, what their half-life is like, whether they need once daily or twice daily dosing. Obviously, once daily is going to be preferred here. And then actually, a lot of them tend to actually be prodrugs, so they have to get converted over in the liver to their actual activated form. So a couple of examples of those that don't undergo that, things like captopril and lisinopril don't actually need that. And so they may be better in a patient with, say, liver dysfunction. In order to avoid that issue there, maybe they can't convert enough of the other drugs over to the active form. This might be good ones for them. But for instance, there's a drug called enalapril. And again, that's how you're going to know all of your ACE inhibitors because they end with pril. Enalapril is the prodrug form we give orally. If I want to give that drug IV, I give the active form. So if you ever see enalaprilat, the AT on the end of there, that just means it's the activated form, right? So if you ever see that, that's what that is. So again, we have quite a few of these drugs here, and again, this is one of those things where drug companies were like, well, wow, they're making really good money off of this ACE inhibitor thing. We should probably make our own and put it out on the market. So you see a ton of them that are out there, and again, most of the time, you're going to find the difference is going to be what insurance is going to cover. Compliance in terms of like how frequently they need to be dosed. These are things you're going to be looking at for these drugs because overall, they all work relatively the same. Okay, so you have captopril, lisinopril, enalapril. I mentioned the enalaprilat's the IV form. You're going to have benazepril, fosinapril, trindolapril. There's a whole other slide of these. Quinapril, ramipril, perindopril, moexapril, and I put perindopril twice because that's where I get my checks from. I'm just kidding. Anyway, goes to show you though that there's quite a few of these. Right, I'd gone through so many of them that I forgot. I just put that one on there like two entries ago. Right, so that shows how many there are. Because there's a lot of like me too. Like, hey, this is making good money. Let's put our own version out there. Right. So anyway, as I mentioned, most of them are going to be once daily dosing, except for captopril. That one has a little bit shorter duration of action, and so that one requires a little bit more frequent dosing. It could be better if you need like really quick decreases in blood pressure. Sometimes captopril can be good for that. And then you're going to find that depending on the patients, they may find that towards the end of the dosing interval, so say it's the last couple of hours before they get their next dose, you may find the blood pressure start to rise back up because now they're producing more of that angiotensin II, which may require them to use twice daily dosing in those cases there. But generally, you're going to find that you get a pretty big steep dose response curve early on in the lower doses, and at some point you're going to kind of get a flattened out response. There's only kind of so much benefit you can get from these, which is why oftentimes you're going to need combinations of therapies in order to get a patient's blood pressure under control, which we'll talk about later. So again, for these drugs, there's not really a big benefit in increasing the dose higher and higher and higher because it kind of flattens out in that response. So what do we use these for? So hypertension is probably far and away the most common thing here. It's going to help to decrease total peripheral resistance. It's going to decrease systolic and diastolic blood pressure, so it's very good from that standpoint. It's going to decrease that left ventricular hypertrophy, so this is going to be good for those patients. So it helps to decrease preload or afterload. Mainly afterload, right? Because the vessels are now more relaxed. They're going to have an easier time pumping against that, and so that's going to help out with that left ventricular remodeling itself. Not only just that, but also just by blunting the effects of angiotensin II, it's also going to have that direct cellular effect being inhibited as well. As I mentioned, it's preferred in diabetics mainly because of the fact that it has those kidney protective effects. It's not going to reverse their kidney function, but it could slow it down. So used frequently in CHF, this is where we find a lot of mortality benefits for these patients here. So it's going to decrease that left ventricular remodeling and hypertrophy, less afterload as I mentioned. Now it's going to have some minor effect because you're getting less sodium reabsorption. It'll have a minor effect on preload and just getting rid of some of that volume. But for the most part, you're going to see increases in cardiac output, mainly due to the fact that there's less pressure, back pressure for the heart to pump against there. Okay, so this can help to prevent or maybe delay progression to CHF. Very good from that standpoint, and we do see decreased incidence of MIs and hospitalizations, which is fantastic, right? And in general, anyone with left ventricular dysfunction, unless they have a contraindication, they probably need to be on some sort of ACE inhibition, either an ACE inhibitor or an ARB, as we'll see there. Anything blunting the effect of angiotensin II is necessary for those patients, unless you don't like them very much, and then say, don't worry about it, it's fine. I'm just kidding, do no harm, right? Post-MI, as we mentioned, a lot of patients will get put on an ACE inhibitor at post-MI mainly because of that remodeling effect, and we do see decreases in mortality there. And then I mentioned the diabetic nephropathy is going to help slow down the progression. Again, you got to be careful in patients with already existing kidney disease, because you will find that if you start up an ACE inhibitor in those patients abruptly, or you start with too high of a dose, what happens is that efferent arteriole opens right up, and then what do you think it does to the GFR? What happens to the GFR? It's going to diminish pretty drastically there. So again, that's why with a lot of these drugs, especially in older patients, maybe those that don't have a lot of hemodynamic reserve, the mantra is going to be to start low and go slow, right? Glad I didn't hear anyone say go fast as possible, but start low and go slow, because you can always give more drug. It's hard to take it back once you already get that dose, right? So one of the big side effects you're going to see with this, kind of going from the most bothersome all the way up to like the really dangerous ones, but dry cough is going to be very common with your ACE inhibitors, around 5 to 15% of these patients. A lot of times it is due to the fact that you're not metabolizing bradykinin. Those levels build up and they tend to stimulate substance P accumulation in the lungs. Right, substance P we know is responsible for causing pain and irritation, and so when that buildup in the lungs happens, it stimulates that cough response. So even though it's not producing anything that requires cough, mucus or anything like that, they still have that dry cough. And so I actually had a family member who was on an ACE inhibitor, and he almost got divorced over the dry cough. He never noticed it, like he would cough all day long, you know, it didn't really bother him, but his wife was about to throw him out of the house over it. So they said, you've got to get him on something else, and fortunately there's an alternative, which we will see in a few minutes. But again, it's not related to the dose or the specific agent, but just know it can happen to any patients who are taking this. It tends to be a little bit more frequently seen in females, and if it's that bothersome, then it may require taking them off the drug altogether and putting them on a different class. Other effects you're going to see, due to the decrease in aldosterone, you're going to end up seeing increased potassium levels. Okay, so this may be problematic for patients with renal dysfunction or already hyperkalemic. This is going to raise that up even higher. Or imagine if I put them on, say, spironolactone and an ACE inhibitor, or if they were on an ACE inhibitor plus a triamterene or miloride. You can see synergistic increases in potassium there, and that can be problematic for some patients, okay? Or throwing like a substitute or something like that, it can be something to consider. So hypotension is also going to be a risk here. Typically, you're going to find that by starting at a low dose, you can kind of mitigate this to some degree, but you're going to find this is more likely to occur in patients who are like sodium depleted, those who are may have CHF, or if they're on other antihypertensive meds. That synergy there tends to be pretty profound. And so again, starting with like a test dose, and if you had to start one of these medications, if it's one time daily, would you want to start it, say, in the morning time or at night time, do you think? Why at night? Some people said night. Why night? You can just kind of sleep through it, right? So even if they had that effect where they may get that orthostatic hypotension, this is something where they can sleep through it, then that would be beneficial. So sometimes we'll give some of these medications at nighttime at first, and then once they see how they tolerate it, then we'll switch them over to daily dosing, right, with all their other daily meds.
Could there be like a downside where it gets too low at night and you don't realize it or something? No?
Could be. You probably sleep pretty good, right? I'm just kidding. your brain's not perfused. I mean, yeah, the syncopized all night, but slept great. No, main point being is that it could be a problem, right? Imagine if you were giving this along with like a diuretic or something, right? You can cause that effect where they have to get up in the middle of the night or something. I'm not aware of it being really a problem where patients were really that hyperperfused. Again, if you're really that worried about those patients, and those are generally older patients with kind of poor hemodynamic reserve in the first place, you're probably starting off like really low dose and then kind of seeing how they work with it and then titrate up. Yeah, but the theoretical concern for sure. As I mentioned, the renal function impairment is something you can see, and this is going to be in patients who they're really dependent on the angiotensin II to keep that GFR up, right? It's not going to be for healthy patients who have perfectly functioning kidneys. It will be for those that already have a lot of angiotensin II necessity there, okay? Okay, so this is the really serious one you can run into is angioedema. Some people feel it's due to the increase in bradykinin levels, kind of sensitizing the patient to this. And what's interesting though is that you actually, it's really hard to predict who's going to get angioedema and when that occurs. And so they say roughly a third of the people end up getting it kind of within the first couple weeks or so of dosing. A third of people who get it may develop in the first year, and then the other third can have it at any point after they've been taking it. So it could be years they're taking it before it actually pops up here, right? And so what you end up seeing is a really rapid swelling of the nose, the throat, the mouth, everything just gets really swollen, tongue's protruding out of the mouth because it's so swollen, and of course what's the big risk there? Lose the airway, right? So I actually had one patient who was coming in who had taken angiotensin. He actually knew he had an allergy. He had angioedema, a minor case, sometime before, but I guess he really wanted to get his blood pressure under control, and so he decided to go ahead and take it again anyway. I don't know if he forgot or what the case was, but guy comes in and, I mean, just tongue completely protruding out, can't really communicate. He's still breathing, like he can still breathe through his nose, but you can tell he's going that direction where we're really kind of concerned about him. And so what we ended up doing was we sedated him with some ketamine, and ketamine is kind of interesting because the patient was still awake enough he can kind of cooperate with us and he'd still be breathing. It's not like something like propofol, just knock him out completely. But and so we had the patient upright, and we actually had a fiber optic scope with a endotracheal tube over, I guess a nasotracheal tube over it, and we're able to kind of snake that down. And using the fiber optic scope, we can have the camera on and kind of see where to go, and then got the airway that way, and then afterwards we could sedate the patient and keep him on the ventilator till the swelling went down. So kind of interesting case, but you will certainly see that, and that is obviously a medical emergency because that swelling goes up any higher, that airway could be at risk. Okay. And of course, would you want to re-challenge a patient with an ACE inhibitor after they have that reaction? Negative. You would not want to do that. Okay. But we'll talk about an alternative you can potentially use, right? Yes, ma'am.
So if it's not a true allergy, how would you treat angioedema with epinephrine maybe?
That's a good question. I think a lot of people, their gut reaction is to say, well, let's go ahead and treat it like anaphylaxis. But from what I've seen, there's not a whole lot of necessary benefit from doing that. You're better off in a lot of cases just securing the airway and then obviously discontinuing the medication and then just kind of letting it kind of go on its own, right? They don't really get the same sort of like hypotension and stuff as you would see with like true anaphylaxis because this isn't IgE mediated. This is more related specifically to that bradykinin. So, but most patients are probably going to end up getting steroids, Benadryl, and Epi anyway, just because that's they see a swollen airway, they say, hey, let's give it to them, right? And they ask questions later. So that's usually how we should do medicine. Give meds first, ask questions later, right? Don't do that, no. Anyway, so other things we can look at. So fetal morbidity, mortality. This is absolutely contraindicated because this will cause birth defects, potential fetal death, and so these are going to be contraindicated in female patients who need blood pressure control. We'll talk much more about that in the OB-GYN section next semester, so kind of keep that in the back of your brains there. And then here, NSAIDs can decrease the activity, NSAIDs can decrease the antihypertensive effects of the ACE inhibitors. What do you think that is? So it's related to prostaglandin synthesis here, and so normally what you're going to find is that bradykinin we saw was kind of vasodilating, and this effect can be blunted if you're having this relaxation or you're losing this prostaglandin. So, and again, some of it has to do with the kidney effects, like we mentioned before, but some of it has to do with the bradykinin. So it's a minor effect, but just know that by giving an NSAID, you can end up decreasing the antihypertensive effects for those patients. Okay, so as I mentioned, the limiting factors here are that there are alternative pathways to produce angiotensin II. We have things like trypsin and chymase and things like that. They can still produce it. However, what if we were just to go to the receptors and actually block it from there? So we have AT1, AT2 receptors. You typically find that the AT1s are going to be kind of widely expressed throughout the body, whereas AT2 is going to be more so expressed during fetal development and kind of is pretty limited in activity for adults. So AT1 is mainly the big one we're going to be focusing on. And so here you can see that this is responsible for a lot of the vasoconstriction, sodium reabsorption, and all of that. So if I could, instead of inhibiting this enzyme here, just block the receptor, I should get pretty similar effects, right? Right? I think so. What would be the one difference here in terms of, say, any other products being affected? Yeah, bradykinin would be unaffected now, so it would still get metabolized by angiotensin converting enzymes, so bradykinin levels would be high or low as compared to being on like an ACE inhibitor. So an ACE inhibitor causes them to elevate. That's why we saw the angioedema, right? So if I had them on an angiotensin receptor blocker, bradykinin levels would be normal, right? Because it's still being metabolized as it normally would otherwise, okay? So anyway, the angiotensin receptor blockers have a really high binding affinity, slow dissociation at those AT1 receptors there, and they lead to all the same effects as you'd expect to see with the ACE inhibitor. So again, you can kind of think about them as working sort of synonymously in your mind for the most part. And so when looking to compare the two, you're going to find that, and again, actually, someone was asking me about combining the two together. And there could be some theoretical benefit there, but clinically, for the most part, you don't get as much bang from your buck as if you were to add on a medication from, say, a different class altogether. But it is definitely a thought for sure. However, looking here, you're going to find that angiotensin receptor blockers, again, mainly just affecting the AT1. You'll still have some AT2 receptor activation, so that can be affected, but again, it's limited in adults, as we'll see there. However, just note here, the ACE inhibitors tend to be mostly renally eliminated, whereas the ARBs are both renal and through the liver. So if you have someone with like liver dysfunction, maybe an ACE inhibitor is better. If you have someone with renal dysfunction, maybe ARB might be a little bit better for them. Just really depends on what you're looking for there. Okay. However, the big disadvantage here is that the ARBs don't cause that elevation of bradykinin, so you don't get that vasodilating sort of effect. However, you also mitigate your risk for what? Angioedema, and also what else do you avoid? Cough, yeah. So for instance, that family member who was receiving an ACE inhibitor had that really dry, hacky cough. They were to switch them over to an ARB, and then the cough went away because again, the bradykinin levels are back down to normal. Also, the risk for angioedema should go down. There could still be some risk, but the risk is relatively low. So again, this is another group of drugs where you're going to end up seeing a ton of Me Too drugs coming out. So candesartan, olmesartan, losartan, azilsartan, eprosartan, irbesartan, telmisartan, and then valsartan. Okay. Now these have been in the news recently. Anyone know why? Yeah. So I believe it was valsartan. Yes, that one. There was a risk of contamination. It was actually not due to the drug itself, but it was the synthesis of it. They had introduced a carcinogen into the product, and so this was a big deal. And I'm so glad I don't work retail, because imagine if every single patient you had filling at that Walgreens or CVS, you had to switch them over to a different ARB if they were on this. So every patient you see that you put on an angiotensin receptor blocker on valsartan, you had to switch them over to something else. So handle all this pharmacy calls, switch all your patients over, then they had to actually go and get new prescriptions filled. It was a huge problem, right? But because of the cancer risk, they said, well, it was definitely worth it, right? But again, definitely a lot of work that goes into things like this. So a little notable thing there that happened kind of recently in the news. So where we're going to be using these, the same places we're going to use ACE inhibitors. So for hypertension, we're going to use it for kidney protection. For diabetics, we're going to be using it for LV dysfunction. Same exact clinical indications. Again, but if I asked like a test question, I said, patient has a history of angioedema, which would be a good drug to put them on. ARB might be your better option in these cases here, right? Or if I have a patient who says, maybe they've had cough before related to an ACE inhibitor, this might be a good option to switch them over to. So these are things you want to think about. Of course, you can see hyperkalemia, you can see hypotension, this impairment of renal function. All of these are going to be due to the same exact effects as what you ended up seeing with the ACE inhibitors. Okay. And again, yes, ma'am.
If they have better effects and you don't have risk of angioedema or the other thing.
Angioedema, or the cough and angioedema, yeah.
Why wouldn't you just go straight to ARB?
You could, right? You could do that. However, the bradykinin buildup can sometimes cause some vasodilation, so maybe you get a little bit better antihypertensive effect from an ACE inhibitor. maybe it's worth it, maybe not. Just depends on the patient there, right? Could be a cost thing too, right? So the ACE inhibitors were kind of first on the market. So those, like, you can get lisinopril for free, I think, from Publix, or very cheap in a lot of places, versus maybe the ARB is going to be longer before they get on those kind of lists. I think there might be one or two on this list now, but I don't keep up with that as well as I should. But anyway, so those are the big differences between the two there. But you could, I think if you had a patient and you had your choice, I don't think you'd be wrong going one way or the other, right? Unless there's some other, like, previous allergy or something like that to lead you to choose one. Okay, so that's it for the renin-angiotensin aldosterone system inhibitors. Any questions on that? So I can go through the calcium channel blockers, but that's a big section, and so yeah, I saw something like, please no. Please no, sir. Please no. So I'm about halfway through this section, so that's not too bad. Any questions before I'll let you go? Let me check. Yes, ma'am.
My question is with the sexual dysfunction, if it's inhibiting the CGMP from
So you can go back to the thiazides.
yeah, why would it cause if it's increasing dilation?
Yeah, so that's it's a minor effect of the thiazide. So presumably, if it's working the same way as something like sildenafil or Viagra is doing it, you could see, potential alleviation of erectile dysfunction. However, the diuretic effects are stronger there, and so those kind of outweigh that. And so what you end up seeing is that because you're diverting blood flow away, right? Because again, it's looking at what are the vital organs to perfuse, what are the less vital organs. It kind of will divert blood flow away from the genitalia, and that's how you get that induction of the erectile dysfunction. So it's a matter of balancing out the effects there. Versus if you have a drug that just specifically does that, and then that can help to alleviate it. And we'll cover that in urology later on.
Can you review the loop diuretics other actions? Slide it back up at, like, I don't know, like 28 or something.
Slide 20.
Well, it was the one where you drew the really good picture with the prostaglandin on the afferent.
Oh yeah, I already got rid of that.
And then the angiotensin too.
Yep.
On the.
So review the effects on the afferent and efferent
Yes.
arteria. Okay, so let's look. I'll draw this masterpiece once more. I got rid of the drawings. I'm just going to redo it. But anyway, so again, we have our afferent arteriole coming into the glomerulus, right? Our glomerulus here. We have our efferent arteriole coming out. And again, I use the same drawing when you're covering the OB-GYN stuff, so don't worry. You'll see this again. Also, if we're doing like the bladder, this works as well. There's a lot of tubes in the body, as it turns out. But anywho, we're all just big systems of tubes, as you'll see. Anywho, so this is actually the proximal convoluted tubule here, right? So we're having blood flow coming in this direction, right, and blood flow coming out this way. So this is going to be our efferent, afferent arteriole here, okay? So what you're going to find, the big thing that influences how dilated or constricted the afferent arteriole is, one of the big ones is going to be prostaglandins, right? So try to draw with my right hand on a mouse is not going to go well. So prostaglandins are going to be the big thing that causes what? Dilation or constriction? Typically cause dilation to occur, right? So it's going to cause these to open up and allows for more flow to come through here, right? Increase the diameter of the vessel, more blood flow is coming through, more of it can get filtered out, okay? So if I give something that blocks prostaglandin synthesis, like aspirin or ibuprofen or naproxen, any of those would decrease prostaglandin synthesis. What you're going to find is this will cause a vasoconstrictive sort of effect, and it will do what to GFR? It's going to lower it. It's going to decrease it because there's just less, or the diameter is smaller, less blood can get through. Okay, so that's one way you're going to see that being affected. Also, things like norepinephrine from the sympathetic nervous system can also affect this as well. Because again, if you are in a fight or flight response, do you want to be producing a bunch of urine? No, you want to keep the blood volume up. So you can also find that norepi will have a constrictive effect here as well. Okay, now on the efferent side, you're going to find that what's the big thing that causes constriction on this aspect of it? Yeah, angiotensin 2, right? So angiotensin 2. We'll just say 2, is going to be causing this constrictive sort of effect here. I feel like when the police come in and get me for like whatever murders I commit one day, like they're going to see these scribblings and be like, see, he was a madman the entire time. Anywho though, so if I were to give something like an ACE inhibitor, what would you end up seeing happen? So an ACE inhibitor would decrease the activity of Ang2 here, and the efferent arteriole would do what? It would then dilate, right? So by causing that dilation, what does it do to GFR? It decreases it because that back pressure is now gone, right? So you're kind of taking your thumb off of the hose, and you notice that flow is going to go down, right? So that needs that back pressure to some degree here in order to get that GFR up, okay? So this is why if I give someone who is really dependent on prostaglandins to keep that afferent arteriole open, if I give them an NSAID, I can induce acute kidney injury. If I have someone who really needs that angiotensin II to cause that vasoconstriction on the efferent arteriole and give them an ACE inhibitor, I can cause acute kidney injury, right? Opposite mechanisms on opposite vessels, but the same effect. Makes sense? If I give them both at the same time, double bad news, right? Any other questions?
You're saying angiotensin II normally dilates and the ACE it normally constricts.
Angiotensin II normally constricts that vessel, right? Because it's increasing the back pressure. So it's preventing blood from leaving, so more of it's sitting there in the glomerulus, that pressure's higher, and will allow it to, yeah. Got it. Okay, let me look at the board real quick. Let us see. Is angioedema caused by bradykinin in all cases? If so, could you reverse it with treating the patient with angiotensin? Or maybe angiotensin converting enzyme? I don't know. I don't know we have a synthetic way to do that. It's a good question, though. But again, that could be your billion-dollar idea. If you can produce synthetic ACE enzyme, maybe you could treat those patients. I heard a couple times now that your BP drops when you sleep, about 20 millimeters of mercury. If your BP is already general low, like 90/68 or something around that, what would happen to your BP at night? Would you be numb when you wake up? Good question. Again, it's all within general means, right? So again, that 20 millimeters of mercury, that may not be the same for all patients. So if you already had a relatively low resting blood pressure, maybe it's only 5 millimeters of mercury difference, right? Maybe if you were, say, hypertensive, maybe it's going to be much more than that. It's hard to say. But no, your body typically regulates itself pretty well, right? It's going to be able to kind of fix. That's why homeostasis is so important. That's why we have so many different mechanisms here to make sure we keep things kind of running kind of normal, so to speak. Okay. Any other questions? If not, I'll see you guys next time.